I keep it to 8 minutes. There are 5 presentations. 2 minutes per question. Okay, welcome to a busy clinical meeting. We are going to start with medicine one. Dorene will present. We are keeping it to 10 minutes of presentation and 2 minutes for questions because we have 5 registered speakers of you.
Good morning, everyone. I'll be presenting on behalf. Good morning, everyone. I'll be presenting on behalf of Medicine One. So I'd like to show you a few pictures. It's an ECG showing a bradycardia. So any guesses on which will yes, hypothyroidism? Coming to my patient, she's a Mrs. M. She's a 68-year-old female who presented to us with complaints of headache for 3 days, which was persistent, non-progressive, holocranial, moderate intensity, not associated with any early morning worsening or vomiting, with altered sensorium for 1 day, which was noted by relatives as she spoke irrelevantly, intermittently, and also often repeating the same words. She had no history of fever, loss of consciousness, seizures, blurring of vision, no history suggestive of cranial nerve weakness, no history of any limb weakness or imbalance while walking. She had no history of numbness, tingling, cotton on wool sensation prior to the complaints. No history of cough, shortness of breath, chest pain. No history of dysuria, increased frequency of micturition, loin to groin pain. No history of loose stools, constipation, or abdomen pain. She did have a history of a slip and fall 3 days prior to the presentation, which was around 1 day prior to the onset of her symptoms. And she's a known case of hypertension for 5 years, but she was not on medications. She also has a history of a coronary artery disease, which an event 10 years back, but the details was unknown. On examination, her heart rate was 76 beats per minute, which was regular. Blood pressure was 110/80, the narrow pulse pressure. Her respiratory rate was 18 per minute. Temperature was 94 degree Fahrenheit, and her GCS on arrival was 13, E4, V4, and M5. She was not oriented to time, place, and person. Pallor was present. Dry skin was noted. And CNS examination, she was noted to have her pupils was equal and reactive bilaterally. Light reflexes were intact. There was no gross ophthalmoplegia or facial asymmetry. CAG was intact. Tone was normal bilaterally. She was able to lift all 4 limbs against gravity. Her dependent reflexes in her biceps, triceps supinator, knee and ankle was 2+. Plantars or flexors bilaterally. Sensory system and cerebellar system could not be assessed, and there was no meningeal signs on examination. The differentials at this point, which we had considered for her in view of her headache plus altered sensorium with the background of a fall, was a subdural hemorrhage, considering her age sepsis with encephalopathy, hypothyroidism, myxedema, coma, cerebrovascular event, a possibility of a thalamic stroke, in hyponatremia, and atmospheric toxins such as benzodiazepine overdose and an opioid overdose. The reasoning for each of the differentials which we had considered was in view of the fall and followed by altered sensorium in SDH. She had, though we had considered sepsis, she didn't have any fever or any history suggestive of an infective foci. She did have hypothermia and altered sensorium on presentation, making a diagnosis of myxedema likely. Though possibility of a CVA was considered, but she did have significant risk factors, but there was no focal deficits or sensory symptoms on a history. In view of the fall plus decreased intake and altered sensorium, considering hyponatremia, and in view of the hypothermia and CNS depression, we had considered toxins. Looking at her investigations, her hemoglobin was 8.9, normocytic normochromic, with the total counts and platelets was normal. Renal function was normal. She had a sodium level of 120, normal potassium. Her urine routine and chest X-ray was normal. No features of any ongoing infection. As part of her hyponatremia workup, she was noted to have a urine spot sodium of 63. Her CT, we had done a CT brain plane, which had shown that there was the diffuse cerebral atrophy was present. There was no infarct or bleed that was noted. Chest X-ray, she was noted to have cardiomegaly, but there was no patch or any consolidation. Her TSH was noted to be 104 with an FTC of 0.8, which was low normal, and her T3 and T4 was in the range. Her serum cortisol level was normal. In view of her high elevated TSH with low FTC, they had followed it up with her antibodies, in which her antibodies were significantly positive for antithyroglobulin and anti-thyroid peroxidase. At this point, we had revisited her differentials. Her SDH was less likely, it was a normal CT. Sepsis with encephalopathy, her counts was normal. Her blood cultures were negative. In view of the hypothermia, altered sensorium, anormocytic anemia plus cardiomegaly, and an elevated TSH and FTC, a likely diagnosis of a myxedema coma was high likely. Hyponatremia was still part of our initial differentials considered. Coming to my, so out of all the differentials which we had, based on the data that we had diagnosed her with a myxedema coma. My brief this thing on myxedema coma, it's a rare disorder which is noted in long-standing hypothyroidism, which is often untreated. The clinical presentation, they often present with decreased mental status, hypothermia, in serious present like bradycardia, hypotension with a narrow pulse pressure. Metabolic parameters, often they are noted to have hyponatremia and hypoglycemia, and non-pitting edema with a puffy appearance. The treatment which is often prescribed for myxedema, the initial, it's one of the rare emergencies in endocrine where we need to urgently replace thyroid replacement. So we give levothyroxine 200 to 400 mics as a loading, followed by 50 to 100 mics OD, and triiodothyronine also 5 to 20 mics loading, followed by 2.5 to 10 mics Q8H. IV is commonly preferred over oral because when there is a patient who presents with the myxedema, they can have a gut edema which can impair with oral absorption. Hence, IV is always preferred over oral. Hydrocortisone 100 mg Q8H should be given until there is an exclusion of a possible adrenal insufficiency, as most often when the patient has a long-standing hypothyroidism, there can be hyperplasia of the thyrotropes, which can cause other hypopituitarism. So as part of which hypocortisolism can also exist. So in order to avoid an adrenal crisis, we should supplement the patient with hydrocortisone till we have a serum cortisol levels. Other supportive measures predominantly is warming measures for the hypothermia and fluid resuscitations. So what we did in our patient was we had started her on IV levothyroxine and levothyronine, and her altered sensorium had improved drastically within 24 to 48 hours. 3 days later, we had repeated her thyroid profile. Her TSH had drastically decreased to 3.8, and her FTC had improved to 1.24. And she was asymptomatic and she was discharged. She was discharged after 1 week of hospital stay on thyroxine 100 mics OD.
Dorene, first question. You said 110 by 80 millimeter mercury is hypotension. Is that?
No, sir. It was only a narrow.
Can you put up because your final conclusion to justify your diagnosis, you put hypotension plus hypothermia. Okay. Is 110 by 80 a normal pulse pressure or is it a low pulse pressure?
But normal is between 30 to 60. So it is right in the low normal range. It is not hypotension per se. Only the pulse pressure was narrow in her.
110 by 80, that pulse pressure is very normal. So we should not make a diagnosis and then fit our findings into that. You have findings and then fit a diagnosis. So you've gone the reverse way. You found that high TSH and then you looked out for clues which you think that fit the diagnosis. So why did this lady suddenly present at this age? You didn't tell us. She was all fine till 3 days ago, and then suddenly she developed a significant myxedema coma.
She had a slip and fall 3 days back, and she had presented with headache and altered sensorium.
How does that fit into your diagnosis? Headache and altered sensorium, slip and fall. How is that related to myxedema coma?
Myxedema coma was not our initial first thought process. Our first thought process was possibility of a bleed.
What I'm
because
saying,
of
your
the
final diagnosis is just mixed edema coma, but it's not explained. The symptoms and signs which he came are not explained by your final diagnosis. So you should be a bit careful of that. Is it possible that a subdural is missed and the CT is done within the first 6 hours?
Yes, sir.
So ideally, you should repeat a CT again later on or do an MRI. So my worry only is a nice diagnosis. You discussed it nicely, but your fall followed by headache, altered sensorium. The altered sensorium alone can be explained by this mixed edema, but everything else can't be explained by that. So maybe you're putting all your eggs into one basket. We have time for one more question. House?
Hi, Doreen. Nice presentation. I want to commend you on the way you rationalized each of your differentials. It's something for all the registrars to keep adopting for all of your practices so that it's explicit for everybody to see. The other thing you haven't explained is how do these antibodies help in your diagnosis? Two is, did you dig and look for features of hypothyroidism in the past? You know, she's come with only a 3-day symptom. So what did you actively seek for? And the third is, how would you suggest IV treatment? How long should the patient be on IV? When do you change to oral, more on a pragmatic basis? So these 3 questions.
Yes, sir. So she didn't have a history of chronic fatigue. She didn't have a history of chronic fatigue, but which was under evaluated. She has never sought treatment for the same. So we don't have a thyroid level prior to that. And regarding her IV treatment, so initial this IV till they can supplement oral intake improves, we can give IV, because the initial reason why we prefer IV is because of the decreased possibility of a decreased gut absorption. So if the patient is able to tolerate oral well and there's less of a gut edema as possibility, then can be switched over to an IV and to an oral, and can be discharged on an oral supplements.
Third is, how do the antibodies help in your diagnosis here?
So the antibodies.
Could you go to that slide with the antibodies?
So her antibodies are significantly positive. So those who were 68 years old, we had diagnosed her with Hashimoto's thyroiditis at this age. So Hashimoto's thyroiditis can have they're more predisposed to develop into a myxedema.
So I think this aspect, whether you could have explored more, you know, was there more of an autoimmune process? Why should she develop Hashimoto's at this age? How, you know, how does such higher level antibodies correlate to that TSH? The other thing is how the TSH came down so quickly. Yes, something I'm not familiar with, but was that an issue for you all?
No, sir. That was, we had not looked into that specifically.
Sure. Thanks.
Thanks.
Let's give Doreen one more hand. Well done, Doreen. Next, medicine 2.